I think this tool will help transform commissioning across London because it recognises the GPs as commissioners and acknowledges the fact that they're the people that commit most of the resources at the time they see patients. It should also help GPs to think about where care is delivered and hopefully to transfer some services from the hospital into the community and give patients a better experience of that care.
Well, we decided to look at the RIS tool. Basically, we started off as a pilot for PBC information. We were looking at what new tools we could bring to clinicians. And the RIS tool was really quite important for us in being able to look at our whole population and, score them for their likelihood of an admission in the next 12 months. We were using previous stratification tools. This tool we found was better than the previous ones, A, because it included GP information rather than just predicting future hospital admissions on past ones. But the most important aspect was that we found that the clinicians, it was really easy for them to use. It was one click, they could see all their patients on the list, and one click they got through to see all the clinical data was relating to that patient so they can understand why that patient was at a high risk. Well, I think the key challenges for the tool was really in the back office. It's a tool that takes all the hospital data relating to that patient, so inpatients, outpatients, A&E data, so all of that needs to be collected, and then it aims to collect all the GP consultations and medications from, in Somerset, 76 practices. The outcomes of risk have been very much about getting the clinicians, the GPs and the community matrons to understand their populations and to know which of those have been at risk of admission. So it helps them allocate resource, who needs care management plans within the practice, which patients the community matrons should focus on as a priority. And we're also using it for new pilots, like we have a telehealth pilot in Somerset where we have 100 pieces of kit. We started off by developing what we call a high climbers report. So once we ask GPs or community matrons to look at their full risk list, when we keep refreshing it, we don't really want them to look at the full list again. We just want them to look at the movers. How are GPs using the tool? Well, 90% of all GPs in Somerset are submitting their data to us every month for uploading into the tool. 100% of GPs have got access to log in and look at risk either in a GP or an acute-only model. Why do I think they're using it? I think ultimately the important part of risk is its simplicity and its ease of use. It is very quick and easy for a non-data analyst to be able to use. It is very easy to train GPs on it. They get it very quickly.
We use the risk tool within the practice as part of our multidisciplinary team meetings. They're attended by district nurses. We have a community matron who comes, and other members of the community team. We literally project the patient list up on the wall and look down the list as it changes. People are looking to it as a resource to help them to manage their budgets because they're not sure where their money's being spent, and certainly the other tools that are available have more of a feel of an accounting tool rather than a clinical tool. So in that sense it's been much more clinician friendly. As an audit tool and personal development tool, I think it's also had some success. There's one practice who identify people at high risk from the risk tool, then let the receptionists know who these individuals were so that if they did make contact, that they were dealt with as a priority by the on-call doctor. It's been very useful in identifying groups of patients who you wouldn't otherwise expect to be at high risk of admission. One would normally expect the elderly, frail, or people with severe long-term conditions. But for example, it's thrown up alcoholics as people at risk. And in one case it identified a child who was essentially using secondary care for their primary care services. And we were able to actually intervene and help them to use their GP services more appropriately.
The additional ways that we're using the RIS product is with the new initiative of telehealth, which is the assisted technology monitoring. We've been able to utilise the information that identifies patients at high risk who may benefit from this additional technology. It was a way of looking at specific conditions that respond well to this kind of monitoring and intervention, and actually has enabled us to utilise the resources that we have in a very efficient way that we would not have been able to, I think, without it.
One of the challenges we face in the future will be the move from where we are at the moment, running an innovative pilot in collaboration with our local PCT, to taking on the responsibilities of a statutory body with all the must-dos associated with that. There are all sorts of implications from that, including the need for information and how risk and accountability is managed. I see one of the enormous advantages of this is that clinicians are both in the driving seat making clinically appropriate decisions about commissioning, but also there is a sense of ownership of the problem. The problem is everybody's problem, in that if we overspend, that has a very negative impact on the service as a whole. And I see this as ultimately a route to engagement as an absolute must-do. It's important for us to engage with the CWP agenda and be innovative. We've been careful to make that part of our change plan for year one. The tools that we're going to need to help us achieve outcome targets include common databases between different agencies so that we can appropriately benchmark and share data in a timely fashion that's accurate and easily accessible to everybody involved in contact with patients. And that will include patients presenting in an out-of-hours setting. We've been starting to use health numerics as a way of mapping the needs of our population and understanding priorities for patient review. Invoice validation is done both by the PCT, and data is devolved down to practices. But this is quite clunky and difficult for practices sometimes to understand exactly what they're looking at and to be doing this in an efficient manner. I guess there are two main areas. One is a logic check to look for obvious anomalies in data, and at the same time a clinical review to make sure that the claim makes sense in terms of that patient's care. I'm a working GP and I know what the pressures are. I couldn't claim to be an IT specialist. I'm interested in using tools that are easy to use and allow me as a clinician to make sense of the information that's being presented to me.